Good morning, and thank you to the organizer for this kind invitation. And I will talk this morning about the MRD assessment in multiple myeloma, particularly on the possibility to implement this technology in the daily clinical practice. The disease dynamics of multiple myeloma is characterized by alternating phases of response to therapy, loss of response, and disease recurrence. And the response to therapy is commonly evaluated by measuring the reduction of tumor burden. And the depth of response has been correlated to long-term outcome. Also, the change in the genomic landscape of tumor clones driven by the selective pressure of therapy also might impact on the duration of the response. However, the amount of residual cells in responder patients is commonly considered the best predictor of outcome in multiple myeloma. Therefore, over the years, several approaches have been employed in order to reliably measure the residual tumor burden. And for a long time, the different categories of response to therapy have been clearly defined by the serological assessment of peripheral markers and by counting the bone marrow plasma cells. However, the recent improvement in multiple myeloma therapy by prolonging the duration of the response in a progressively increased number of patients have highlighted the need of more sensitive technique able to overcome the limit of detection of conventional approaches. And therefore, today, the MRD assessment in the bone marrow by high-throughput technology is considered the best tool that we have available to measure the efficacy of treatment. And this has been demonstrated in all clinical contexts, showing that the amount of residual cells in responder patients is inversely correlated to the probability of progression. More importantly, the possibility to employ high-throughput technology has allowed to refine the definition of conventionally defined response categories, showing that patients in complete response, highlighted in yellow in these survival curves, the clinical outcome of these patients, the good clinical outcome of these patients, it is actually due to the presence among them of patients with undetectable residual disease, and that this particular category of patients, the MRD negative patients, shown in blue in this survival curve, are those with the best clinical outcome, whereas patients in CR but MRD positive behave similarly to patients in near CR or in VGPR. Therefore, the depth of response and of MRD negativity has become very important to be defined, and it has become a challenge, the definition of the optimal sensitivity threshold for the definition of MRD negativity. In fact, it has been clearly shown that patients can be stratified in different categories with different outcome according to the amount of residual disease. And since the high sensitivity means higher costs, it has become a challenge to balance the cost, to reach a balance between cost and benefit in order to define which cost might be affordable in order to reach the highest sensitivity needed to manage patients, not forgetting that MRD assay employed needs to discriminate between different levels of residual disease. Concerning the method employed to evaluate MRD, providing that a deep MRD result is obtained, it is worth it to say that the clinical impact of negative results is not conditioned by the method employed. And this is because the most commonly employed approaches for MRD assessment, particularly in their next generation version, NGF and NGF, are almost equivalent in terms of sensitivity and specificity. And that the few differences among these two methods, the advantage and disadvantage of the two methods, are easily manageable by expert laboratories. This difference actually should be exploited in order to better describe the residual disease, both by characterizing the residual disease within the bone marrow microenvironment and possibly correctly enumerating them by NGF approaches. So it is now well accepted that MRD negativity is considered the goal if we want to improve patients' prognosis. And since MRD can very efficiently stratify patients in potential responder MRD negative and potential non-responder MRD positive, it is commonly evaluated in the context of clinical trial at different time points with the specific aim to demonstrate that MRD negativity can be employed as prognostic factor to assess the so-called dynamic risk of the disease or as a surrogate endpoint that can more rapidly predict survival in order to accelerate the process of drug development and approval. So, given the huge amount of information, of data that we have available and that show that MRD is the best tool that we have available to predict the myeloma outcome, the next question is whether we might or whether we should implement this technology in the daily clinical practice. And in this particular context, the question that we might answer can be whether we can define a deep remission or predict a clinical progression. In other words, the question is whether we might employ MRD in order to drive clinical decision, such as to stop maintenance in patients who are persistently MRD negative, or whether we might offer an autologous stem cell transplantation to MRD negative patients after induction with very effective quadruplets, or whether we might offer a therapy intensification to patients who turn from MRD negative to MRD positive. However, the possibility to implement the MRD methods in the daily clinical practice is questionable, since we still not have available the results of the clinical trial designed to provide the formal demonstration of the opportunity to take clinical decision according to the results of MRD analysis. And these results will need few years to be available. However, this delay in the attainment of these important results actually give us the time to become familiar with this technology that is not so easy to manage in the daily clinical practice, and to face the challenges that these technologies offer, such as I previously say, the definition of the cutoff for MRD negativity definition, or such as the definition of the timing of MRD evaluation. In fact, it has been demonstrated that MRD negativity impacts patients' prognosis, particularly when it is sustained for at least 6 or possibly 12 months, as shown by these survival curves. And these important clinical results, together with the fact that serial MRD testing might be even more informative than the single one, as shown by this study, where patients with continuously declining detectable clone behave similarly to patients in persistent MRD negativity, as opposed to patients with a stable or growing number of clones, as shown here, both suggest that since repeated MRD measurement should be planned in order to be more precise in defining the patient's prognosis, again, a balance should be reached between the opportunity to perform repeated MRD analysis, thus being more informative, and the tolerance of patients, possibly frail, repeatedly facing an invasive procedure. Therefore, with this in mind and in spirit of managing all these challenges, we recently decided to implement the MRD analysis in our clinical practice. In our institution, we have available 2 technologies, both NGS-based, The first one is an FDA-approved method, CAVD marked both for clonotype and MRD assessment, which is expensive but also very sensitive, and has been provided to our institution after a tech transfer and its certification, and that we are employing for the management of MRD in the context of clinical trials. Also, we are trying to implement these technologies in the daily practice. The second one is an unvalidated method, commercially available, which is CAVD marked just for the clonotype assessment, that is less sensitive and also less expensive, that we are employing in the context of the daily practice. And also we are trying to validate in the context of an Italian network of 5 laboratories in order to validate this method. With this last approach, we are actually managing approximately 200 newly diagnosed patients, and we are actually monitoring the minimal residual disease in half of them. So to conclude, I would like to raise a last question, that is, are we doing enough by employing high throughput technologies to assess MRD and to assess the disease dynamics in multiple myeloma? In fact, even by achieving the most highest sensitivity achievable, that is 10 to minus 6, it is a common observation that there are few patients MRD positive, persistent MRD positive, that do not relapse, and also that there are MRD patients who are MRD negative patients who relapse earlier than expected. And it is important to acknowledge that among patients who do not relapse but are still MRD positive, there are few who have the so-called MGUS-like behavior, and that probably this particular type of patients would not need additional treatment in order to preserve their response to therapy. And also among negative patients, there are few with residual cells very aggressive, still undetectable, which are the reason of the early relapse, that on the contrary might need an early intervention. So, to answer the question whether we should introduce MRD in the daily clinical practice, I would say yes, we should try to test this technology and to manage all the challenges that it offers, still keeping in mind that probably by analyzing the bone marrow tumor burden, by analyzing the quantification of bone marrow tumor burden, we are not doing enough. This might not be sufficient to fully explain the patient's outcome. And with this, I would like to thank all my collaborators in the molecular biology lab in Bologna and you for your attention.